the third session for today on the role of keto analogs in low protein diet. I would like to request the chairpersons, Dr. Tarun Shah sir, Senior Consultant and Head, Department of Nephrology, Yashoda Hospital, Somajigoda. Dr. Sati Reddy sir, Senior Consultant and Head of Department, Nephrology, KIMS Hospital. Dr. Shrikant sir, Senior Consultant, Department of Nephrology, Asian Institute of Nephrology and Urology Hospitals, Banjara Hills, Hyderabad. And Dr. Anuradha ma'am, Associate Professor, Department of Nephrology, Osmania Medical College and General Hospital, Hyderabad.
Morning everybody. Without wasting much time, I am very impressed by the time discipline of the last session. So we'll go ahead with the talk. First talk is by Dr. K.S. Nayak. Sir, please. So Dr. K.S. Nayak is well known among nephrology circles. He is a post-counselor of the International Society of Renal Nutrition and Metabolism, regular speaker at these congresses, and he's won many accolades and awards. Over to you, sir.
This one. Thank you, chairpersons, and thank you, organizers. It's 20 minutes. Role of keto analogs in low protein diet. It will lean heavily on our personal work and currently available data on this. This is a WHO statement that diet is fundamental. It's a global CKD is a global health challenge, and diet is the largest CKD-related risk factor for death and disability, coming none other than from the WHO. And they say that 0.6 gram per protein per kg is more than enough to maintain adequate nutrition, provided there are no hypercatabolic states or other such conditions. And medical nutrition therapy has become a very, very important. So has the role of dietitians. And we clearly know that in early stages of CKD, diet intervention slows CKD progression. Later stage delays the need for dialysis. I'm straight away jumping to vegetarianism because that has become now the new panacea for restricting progression of kidney disease. I'll add progression of kidney disease, and I'm going to talk about vegetarianism, concept, benefits, pitfalls, and then the keto analogs, new developments and conclusions. Actually, the word vegetar means the Latin root for giving strength or health. Elephants are vegetarians. They have the highest muscle mass among living mammals. Sherpas are vegetarians. So the concept that vegetarianism doesn't give, there are so many international athletes who are vegetarians. So it doesn't, it's a wrong sense that vegetarianism doesn't give them enough protein to make muscle mass. I won't talk much about veganism and vegetarian, but the vegetarianism sometimes is used interchangeably with veganism, but veganism is more strict. Anything coming from animal source, like such as even milk or honey, is not supposed to be used. Whereas vegetarianism depends on whether you are over-lacto-vegetarian, you can have milk, you can have dairy products. The small tips which I think the dietitians would be better off have: small frequent meals if you are a vegetarian. There was a study, and even our analysis of patients show that the estimated dietary protein intake in patients with CKD who are on an unrestricted vegetarian diet is 0.64 plus minus 0.15. I think Shruti mentioned about it, and we have seen that in our patients also. In CKD patients, dietary protein should not be restricted unless they are supplemented with keto analogs or amino acids. This is very, very important. So a dietitian's role and proper assessment is very, very important. We can use, if people are addicted to meat, we can give them meat like tasting things that I've shown there: soy protein, tempeh, nut butters, and unsalted nuts, natto. One of them, tastes almost like red meat, but it's plant source. So this is the most important slide I would like to highlight is any patient who is going to be put on keto analogs has to have an assessment of their urea nitrogen assessment. And if it falls below, as I think correctly Dr. Rana said, we have to assess that and make sure that their protein intake is adequate and they are not malnutrition. So here is the formula. We do urea nitrogen estimation in the urine, and we have to multiply it by 6.25, and most of our patients were taking about, vegetarian patients were taking about 45 grams of protein. This value is very important for initial assessment and later on compliance. You might give a patient a 0.6 or 0.8 gram protein, but they might not be taking it, or they might even exceed. This is a problem with the Western population. They have a problem coming down to 0.8. So that serves both purposes of monitoring and ensuring that they're taking the adequate protein intake. And the SGA is very, very, very important for the nutritionist, the dietitian, to make sure that they are not malnutrition. Only if they pass this test can we put them on keto analogs along with the protein restriction, which we generally go for 0.6 to 0.8. The benefits are plenty. Here's a very nice study of identical twins, which, if you can see, 22 healthy, similar, what you call, the twins were put on omnivorous diet and the vegetarian diet, and they had totally different outcomes. The one with on the vegetarian diet did not have any of the comorbidities that the patient, that the other identical twin developed on an omnivorous diet. This is one of the first people who I think most of us seniors were reading these nephrology forums. So this came in the forum, and clearly 20 people in over 3 weeks were given a non-veg diet and animal protein diet and a plant-based diet. And the plant-based diet, significantly, you can see the graphs there, reduced hyperfiltration and reduced renal plasma flow. And the glomerulus was protected because of this. This was another study which clearly showed the benefits, the CRIC study, which showed the benefits of adherence to plant-based diet and risk of CKD progression on all-cause mortality. The ERIC study was a huge study, followed up for 23 years, a total of 2,632 patients. We found that those on proteins from vegetable and dietary source had a reduced risk of incident chronic kidney disease, and they were on a vegetarian diet, and the ones not on vegetarian dietary protein were having comorbidities and CKD incidents. Same thing with the NAIN study, and also the subgroup of people called the Adventists, who are, as a health message, advocate vegetarianism, did far better than those who were on omnivorous or protein-based diets. The plateau diet has become very important, and now almost every patient of ours, in India it's not very difficult to put a patient on vegetarian diet because they consider eating meat as a sin, especially our group of patients. So we put them on a plateau diet, which is bland dominant low protein diet. The complex carbohydrate are used. The protein source comes from, more than 50% comes from plant dominant diet. Low protein diet, 0.6 to 0.8 grams. Sodium personalized, but less than 4 grams. High fiber, adequate energy, and close monitoring by the dietitian. So the glomerulus is protected because of this. Exactly what the RAS inhibitors do, they do more than that. And the glomerulus is, we have the, Cam wrote a editorial in the New England Journal of Medicine. So the intraglomerular pressure falls down with vegetarian diets. Another important thing is the reduction of decreased acid load. We don't realize how much damage metabolic acidosis can do to CKD progression. It's a vicious cycle. As the acidosis increases, the interstitial fibrosis increases, there's upregulation of some of the enzymes, and it becomes a perpetuating problem, and ultimately they end up with the ESRD. So if the metabolic acidosis comes down, which the vegetarian diets do, vegetarian have much less metabolic acidosis than animal protein. Vegetarianism, people on multiple studies have shown that their blood pressures are better than the animal protein, and they also have less incidence of diabetes than the omnivores if they are put on a vegetarian diet. The gut microbiota is becoming very, very important now. The leaky gut syndrome happens more with the animal protein, and we all know the deleterious effects of the leaky gut syndrome, and vegetarian diets tighten the tight junctions near the luminal surface and prevent the endotoxin movement from the pathobionts into the lumen and cause a lot of what you call self-propagating problems with the cardiac, neurogenic, and also the progression of chronic kidney disease. We ourselves have done a study, the PROX study, probiotics, the conservative treatment of chronic kidney disease. This has been already addressed, the potassium part. I think dietitian Sinha has done it. So high fiber diet increases gut motility, so there is less potassium burden, and there is less phosphorus because phytates bind the phosphorus. The pitfalls, dietitians are very important. We have to brief the dietitians. Don't make as someone raised the point, don't raise the, as it is a difficult proposition to follow the dietary restrictions. Give them a little bit of incentives, and risk of PW if it is not properly monitored. So unless Ka is supplemented. For your information, if you give the full dose of ketonologues, which is 6 tablets per day, then you're giving 0.3 grams of high biological value protein per day. That has to be added to whatever is the protein restriction you are doing. So if you reach about 0.8, that is enough, and you are not, but not in a malnutrition patient. So obesity has to be managed, low glycemic index, plant-based diet has to be given, palatability has to be improved, nutrition deficiency, which the previous speaker spoke, they have to be monitored, and intensive monitoring by nutritional. So this is, they are the keystone, the renal dietitian team, they are the keystone, and as Georgie said, BIA is something that we regularly do, and vegetarianism with ketonologues. This is a very nice study, vegetarian diet by Piccoli, and you can see over 1.5 years, the only problem with the Western people is the compliance. They find it difficult to reduce their protein, but in India we have no problem. The compliant patients did very well in this study group, and as I said, in Indian patients not a problem. The major paradigm shift in going toward vegetarian diet was started by Liliana Garneta from Romania. I have interacted with her. Her initial study was on non-diabetics, but subsequently she's now doing a study on diabetic patients with vegetarian diet, and she put them on VLPD, that's 0.3 grams and 0.6 grams, and a significant portion of them did not reach the dialysis stage, as you can see in those graphs. And 50% reduction of EGFR was markedly reduced, and the decline in EGFR was significantly reduced. Now, this is the study we did, where we found that we put in 178 adult patients, stage 3 to 5. 122 patients were on SLPD, which is 0.6 gram, and we put them on 1 tablet for 10 kgs, and 56 patients on 0.3 grams and 1 tablet for 5 kg. What we found was that over a period of 12 months, their creatinine clearance was calculated using the 24-hour urinary sample collection. Urine nitrogen estimation was done to make sure that they were compliant. There was negligible screen failure, and about 92% of our patients were on vegetarian diet. Excellent results we had. And that's why this is again, I'm repeating the slide. We did this assessment and enrolled only patients who were not malnutrition or not taking enough proteins. This has been off-quoted, the only double-blind study done by Prakash from Delhi, and he showed fantastic results with on a double-blind study with placebo and keto analogs. And the newer developments, we have a lot of new drugs that have come. Among them, we have to be very careful not to forget the RAS inhibitors. We have the GLP-1 inhibitors, we have finerenone, we have especially the SGLT2 inhibitors. So we have a lot of study coming into both in chronic kidney disease of diabetic and non-diabetic origin, and some more studies here. The only thing I can say is all of them are industry driven. I have personally used GLP-1 agonists, and I found that they develop severe sarcopenia and GI disturbances. At least about 60 patients of them could not tolerate the semaglutide, or I didn't put them on, I put them on oral semaglutide. The tolerance level of patients, and they developed classical turkey neck, loss of muscle mass. So the muscle mass loss itself can reduce the creatinine, serum creatinines. I am more favorable towards SGLT2 inhibitors because they are much better, and we have a study which but the keto analogs are an orphan. The MDRD study, totally it's a flawed study. Erroneous assumptions were made, and actually the long-term follow-up of them, you won't believe this, the social security card data was used for long-term follow-up detail. Can you believe this? This is like a glorified, in the US, it's like a glorified Aadhaar card. So Aadhaar card was used, something like Aadhaar quote unquote, was used to get the follow-up study data. And there was a conflict of interest because one of the principal authors of this study, MDRD study, was associate editor of the article in which the paper was published, the American Journal of Kidney Diseases. So I would give it, but there are no pharma studies supporting, it's an orphan, the keto analogs, and I think we have to be, so this is the study I would say, we have to be proactive in getting keto analogs studied. This is the Sijasan study which came recently, which says combining keto acids, keto analogs with SGLT2 inhibitors is like 1 plus 1 is equal to 2 or maybe 3. You can combine them together. And the FIND CKD study has been terminated early because the Bayer study on finerenone, that also has shown. So we have a lot of possibilities coming up now. And now we are into doing a lot of AI in following up the CKD patient, both the longitudinal and as George said, we are looking at the importance of BIA in this. We do, on the right side you can see, we create a metabolic twin, and all the features that we do with multiple instruments is put into the metabolic twin, and we see how we can manipulate the metabolic twin after follow-up regularly. So the body composition meter monitoring is one of the important things about that. So AI can be a catalyst for the new standard of management of CKD. We are now actively using, I have about 20 patients now being followed up on this particular platform, and the conclusions are even the KDOK clearly says it gives in non-diabetic patients, it gives a 1A recommendation that you can go ahead with keto analogs and low protein diet. The International Society of Renal Nutrition and Metabolism, of which I was the past counselor, also says that it is an important part in the future management of delaying progression of CKD. And a final, the confusion about 0.8 gram or 1.3 grams. I think the last para you can see a more reasonable practical approach would be to aim for a dietary protein intake of 0.6 to 0.8 grams. This can be further refined towards the lower end of the DPI range, which is 0.6 if they are on SVLPD. or plant-based diet as we are using. So,
Dr. Nayak,
yeah, to sum up,
keep 1 minute for discussion. 1 minute 42 seconds left.
And NKF guidelines strongly support LPD diets with ketone supplementation in non-diabetics. We believe that mechanism of action is similar as in diabetics. So why should not DKD, diabetic kidney disease, also benefit from keto analogs and plant-based diet? Garniata study changed the entire thought process of vegetarian diets. Malnutrition needs to be addressed prior to SLPD initiation. Supplementation mandatory to compensate for lack of protein of high biological value. A Plado diet, a plant-based diet, should be is beneficial. Ideally, however, RCTs by industry should be performed. The small graph down there is use it in the right dose at the right time in the right patient. Given the present knowledge, vegetarian diet with Ka in a carefully selected compliant population is reasonable. It's easier in India with high prevalence of vegetarianism. Ka supplementation, as I said, should be in the right dose to achieve optimum benefits. My go-home message is, if you change nothing, nothing will change. And I hope, rather than being skeptics of low-protein diet, which is something that has been going on for the last 5-6 decades, we should embrace it, but use it properly to achieve the desired results. Thank you very much.
Thank you, Dr. Nayak, for a very elaborative and thought-provoking talk. I just wanted to say that when you are providing vegetarian diet, we need to ensure that patient gets 30 to 35 kilocalorie of body weight calorie. Otherwise, even in a low protein diet, people will be more and more malnourished. Second thing is that, are there any data to show the survival benefit? No, I'm not talking about the renal survival, mortality benefit with the low protein diet and keto analog supplements?
Yeah, there are, but I haven't quoted them.
Yeah, because what I found when I was trying to read, that the mortality benefit is not established. The progression benefit can be shown because it is basically causing the sort of shrinking of the, less hyperfiltration, and thereby your creatinine may not increase so much. But the mortality benefit has never been proved beyond doubt.
Okay, no, I will, if you allow me the time. A friend of mine, Guglielmo Brunori and Locatelli, both have put elderly patients on either dialysis. I mean, this may be shocking to those who don't know about this.
That is stage 5.
Yeah, in stage 5, they have put elderly patients on dialysis, and they have put some of them on keto analog only with the protein, and they showed that the survival of the patients on non-dialysis was double that of dialysis patients.
Yeah, but we are talking about the prevention of progression.
Correct, yeah, so that should give you an idea.
Not in dialysis patients. That is a different entity.
So, not on dialysis, yeah. Yeah, we I mean, this is one of the examples I can give, but yeah, I did not show it, but there is enough evidence.
So, anyone, any comments and questions? Dr. Georgie?
I thought your examinership is over.
Thank you. So, if there are no comments and questions from anybody, yeah.
Sir, what is our take-home message, whether to use keto analogs or not to use?
You should use it properly, and we have wonderful results. But it is not one BD, one TDS. It has to be given, and proper nutrition involvement and proper assessment, you are only going to benefit. The new trend would be, because keto analogs can be used from stage 2 to stage 5 pre-dialysis, but better to use it earlier than later. Use the proper dose, do proper nutritional counseling. You'll see, I have seen dialysis patients who are anorectic, and I've started them on keto analogs. Within 1 week, their appetite comes back. So it is definitely a very good drug. But with the newer developments, it can be used in combination.
Thank you, Dr. Nayak. Dr. Georgie, did we chairpersons also pass the exam or not? Thank you, sir. Yes. Thank you.